Good evening, everybody, and welcome to the Newborn Screening Forum for 2023. This is actually the first of two forums planned for the year, and this one is revisiting an old condition that we've been running for around 50 years, congenital hypothyroidism, but introducing a revised recollection guideline for premature and sick neonates. Oops, sorry. The first thing I would like to do is to acknowledge country and to start the proceedings and acknowledge the Aboriginal and Torres Strait Islander people as the original custodians of the land on which we inhabit. And on behalf of all speakers here, we pay our respects to the elders past, present, and emerging. It's really important to also acknowledge the wonderful team that makes up newborn screening. So this really starts at the maternity services and then flows through to the laboratories of the Victorian Clinical Genetics Services, and also the many people behind this, including the people for tonight's webinar. And we can't forget also all of the doctors and nurses and professional staff that are involved in the referral of sick newborns. Everyone plays their parts in making sure this screening program works for the babies of Victoria. And of course, it's the acknowledgement of our wonderful team at the Department of Health Victoria that funds this program and makes it all possible for us and the babies. So tonight, you have me here as the Deputy Head of Biochemical Genetics and leading the newborn screening program in Victoria on the laboratory. We have our guest speaker, Dr. Natasha Heather from New Zealand's program, and she's going to talk about congenital hypothyroidism, and she is a paediatric endocrinologist and chairs a number of committees associated with newborn screening. Our next speaker is Mrs. Sally Morrissey, and she will be well known to many of you on this forum. And Sally is our nurse educator for the Victorian Clinical Genetics Services and the newborn screening program. And Sally will talk to you about our revision of the protocol for our preterm and sick neonates and the why we are doing this. Of course, with any education session, we have learning objectives, and the learning objectives for this evening are around congenital hypothyroidism, screening, and the why we are doing this, and our specimen collection guidelines, and why we're asking you for repeat samples for our preterm babies. Just to put some things in perspective, congenital hypothyroidism started almost 50 years ago in Victoria, and it was the second condition introduced into newborn screening. And you can see with this graph, we've now screened in Victoria over 3 million babies. And over each decade, we've added a screening condition. Then we had a little bit of hiatus in the early 2000s, where we haven't really added any new conditions. But that's all changing, and it started with last year with the introduction of CAH screening and is continuing this year with SCIDS and SMA screening. And I'd like to just give you a little bit of an insight on some of the things to come and some of the why we are introducing more screening quite rapidly. So back in 2017, there was a national blood spot screening national policy framework introduced, and there has been a momentum since then looking at conditions for introduction and also for harmonisation of services across Australia. So the 5 services in Australia are all working hard with doing some form of implementation. So the next ones on the list after SCIDS and SMA, which will be rolled out this year, the government is looking at X-linked ALD, adrenoleukodystrophy. That's under a health technology assessment at the moment. And they're also looking at sickle cell disease as with a health technology assessment. And as I said, there's also the harmonisation initiative by the Albanese government, which is in play as well. So there is a lot happening, and we will continue to offer forums to you to be able to bring you the latest updates for newborn screening. So this is the last of my slides, and it's now my great pleasure to be able to introduce my friend, Dr. Natasha Heather from New Zealand, to talk to you about the importance of congenital hypothyroidism. And thank you very much, Natasha, for spending the evening with us.
You're very welcome. I will just bring up my slide, and I think that looks good. Hello, everyone, and thank you for the invitation to talk with you all tonight. I am from New Zealand, but I can assure you that congenital hypothyroidism is the same all around the world. And the way that we screen for it and manage it in New Zealand is very similar to in Victoria. And as Rhonda said, this was one of the first disorders to be added to newborn screening programs across Australia and New Zealand. So it's something that we have quite a lot of combined experience with. Now, congenital hypothyroidism is relatively common in that it's about 1 in 2,000, every 2,000 babies will be affected. And most often it's caused by the thyroid gland not forming properly. There's a really simple test. So that's a high level of TSH on the blood spot card. And a simple and inexpensive treatment, which is just oral replacement with the thyroxine hormone. At the same time, hypothyroidism is difficult to detect clinically at birth. So without screening, affected babies might present clinically in the first couple of months of life with jaundice, feeding issues, growing poorly, or they might present even later towards the end of the first year or beyond, with slow development, poor growth, and permanent intellectual disability. So in many ways, screening for hypothyroidism is a really good thing. And in fact, it's recognized to be one of the most successful public health measures of the past century and absolutely meets screening criteria. So I completely endorse the idea of having an educational update on congenital hypothyroidism, even though you guys have been doing it for so long, because it is just it's just an absolutely essential part of the program to be getting right. Now, of course, for parents, when they get a positive newborn screen result in their otherwise perfect, healthy newborn baby, it's a massive shock. And so what I always say is trying to be reassuring by emphasizing that it's a serious but really, really treatable problem. So screening, of course, is not foolproof, and it's not a diagnostic test. It's really just a sieve to find babies who are more likely to have a disorder as opposed to those who probably don't have it. So every positive screen must be followed by a diagnostic test. And of course, screening will always miss cases. So clinical vigilance is always going to be important for hypothyroidism and all the other disorders that the screening program targets. Now, newborn screening is often thought of something that happens within a lab, where really the system, as you all know, is much more complicated than that. And that includes the nurses and the midwives who explain what blood spot screening is and make the offer to families who consent for their babies to take part, the process of getting the samples to the lab quickly, and then reliably testing, reporting, and of course the follow-up care. So all of those aspects have to work well together for good screening to happen. Now, here's an example of a missed case of congenital hypothyroidism in New Zealand, where both the midwife and the parents, in fact, did not realize that the baby hadn't been screened. So this baby was taken into an emergency department 6 weeks of age because they were sleepy and not feeding well. And thankfully, a really onto it pediatrician noticed the signs of hypothyroidism and checked thyroid function. And in fact, this baby had been born without a thyroid gland and was profoundly hypothyroid. So ideally, they would have been picked up earlier through their newborn screen, but these problems will happen from time to time, and much better to be picked up at 6 weeks than later. So, of course, the goal of newborn screening is not just picking up cases, but to help the babies who are picked up to have good lives. And for hypothyroidism, what that really means is that we want them to grow up to be tall and smart. And that depends on this screening pathway working well, with baby being picked up with a positive screen in the first couple of weeks of life, and then the treatment factors throughout early childhood and beyond. And of course, everyone wants kids with congenital hypothyroidism to have a normal outcome. But early reports suggested that most would have some long-term issues, especially in motor and cognitive performance. And these were related to how severe the disease was, how quickly treatment was started. But I guess the thinking was that if these babies haven't had enough thyroxine in utero, the outcome will never be as good as their siblings might be. So in New Zealand, we usually pick up babies with congenital hypothyroidism in the first couple of weeks of life, as you do in Victoria. And for quite some time, we followed this particular protocol, which involves a loading dose of thyroxine and quite intensive blood tests, with the purpose of ensuring that thyroid hormone replacement is in the right dose, and that the hormone levels are as close to normal as possible. And then almost 10 years ago now, we did an outcome study, which was very reassuring. So that looked at 44 kids with congenital hypothyroidism picked up through our screening program and their siblings, and we assessed their IQ and their development in mid-childhood. And in fact, what we found is that the kids with congenital hypothyroidism did no worse than their siblings in all aspects of the assessment. And even more than this, there were no variables, so severe disease or other markers which were associated with worse outcomes. And we found this really, really reassuring. And this is why I think we can tell parents of babies with congenital hypothyroidism that we expect their kids to do really well. And in fact, we expect them to end up just as tall and smart as their siblings, or if they didn't have congenital hypothyroidism. Now, when faced with an unexpected diagnosis, parents understandably will often go looking for information on the internet. And when they go looking into hypothyroidism, they might find some really quite upsetting things about cretinism and poor outcomes. So I think that one of the best ways to support parents is to direct them to good websites and sources of information. And one reference that I think is particularly good are some family videos that our New Zealand Ministry of Health funded as part of our 50th anniversary. So they're only a couple of years old now. I'm talking to families of kids with congenital hypothyroidism and other disorders about their journey. So they talk about the shock of getting the diagnosis, and then, you know, how things went and how they feel now that their kids are a bit older. There's really good information. I was having a look around on congenital hypothyroidism in the Better Health Channel Victorian website. And I know that the paediatricians as well would direct families to really good sources through ANSPED and other professional societies. So moving now to preterm babies with congenital hypothyroidism, because they're a really special population, and this case is a good example. So it's an extreme preterm baby at 25 weeks, 750 grams. And as you can see, their day 2 TSH was completely normal. And like you guys, we have a system of routine repeat samples. So this next sample was collected at 2 weeks of age and was borderline positive, mildly elevated TSH level. So we notified the NICU, who arranged some blood tests, which in fact found a much more severe biochemical disease than we were expecting. Certainly, if you consider that the day 2 newborn screening sample had been completely normal. Sorry, this is a summary of hypothyroid cases in extreme preterm babies from 2021. And in fact, our incidence within that population was about 1 in 30. So much, much more common than the 1 in 2000 in the general population. And I guess the features that I wanted to point out really are that when you look at the day 2 newborn screening TSH levels, they are almost always normal. And then it's not till 2 weeks, a month, that you start to pick up that the TSH is raised. And then what you can see on the diagnostic thyroid function tests is even much more severe. Of course, some have normalized, but some are much more severe. So this is not a trivial problem with these babies. So how can screening best help preterm babies? I think step 1 is to understand that they are not just small term babies, and they really do deserve their own approach. And the first reason for that, of course, is that hypothyroidism is much more common, 1 in 100 or even more, as we found in 2021. The disease itself is somewhat different. So you might remember they said that in most babies, hypothyroidism is caused by the gland not forming properly. So it could be an ectopic gland or no gland at all. Whereas in preterm babies, there's normally a gland formed in the right place, but it's not functioning properly. And the disease is usually not permanent. So babies have thyroxine replacement for the period that they need it, but not lifelong. The day 2 TSH screening level is almost always normal. And that's thought to be because of immaturity of the hypothalamo-pituitary thyroid axis. So the reason why you get a high TSH in congenital hypothyroidism is because of low thyroid hormone and a lack of feedback means that the TSH goes up. So if the axis is not mature, you have to wait for the axis to mature in order to see the TSH rise. And in essence, that's the rationale for routine screening in preterm babies, which I think is a really essential part of doing their newborn screening well. Thank you. So I'm going to hand over to Sally Morrissey now, who I know needs no introduction.
Hi, everyone. Sally's just having a fraction of a problem with her mic, so I thought we might take the opportunity just to go through a couple of questions, if I may, to Natasha. So, Natasha, there's, besides the congenital, if I may start, besides the congenital hypothyroidism where you've got no gland at all that you showed in that baby at 6 weeks of age, there's also, I think I can hear Sally there.
Yeah, it's okay, continues. I'm so sorry, I don't know what happened.
It's okay.
No.
So besides that baby at 6 weeks of age, we've also got the scenario of the transient hypothyroidism. And that's something that's always confounded me a bit in the newborn screening programs and how we deal with this and when they are truly transient, when they are truly considered transient hypothyroid.
Yeah, thanks. So that's a really good question. And I guess it depends. The diagnosis needs to be made early. So the diagnosis would be made on thyroid function tests and then supported by imaging if that's part of the local protocol. Sometimes the imaging will show that baby must have permanent disease. So if there's no gland at all, or the baby's got an ectopic gland, then you know that there's a structural issue, and that's permanent disease. Whereas if the gland itself looks okay, maybe there's an enzyme that's not working properly in the gland, baby is biochemically hypothyroid, but there's a chance that that baby will only need thyroxine replacement during the early part of life, when in the neonatal period, in the first few years when the need is greatest. So across Australia and New Zealand, pediatricians will often trial babies off thyroxine when they're 2 or 3 years of age, in order to see whether baby still needs thyroxine, or whether they no longer need to take that each day.
Thank you. If I could just do one follow-up question for that, and then I'll hand back over to Sally. So the Prem babies, you said, had a higher incidence of 1 in 30, which is really quite scary. Are they most likely to be the transient in this transient hypothyroid group, do you think, or is it?
Yes, they absolutely are. So the reason why the incidence is so high is unclear. Most people have found that increasingly Prem babies are at increasingly high risk. So the incidence rate of 24 weekers is likely to be higher than the incidence rate of 32 weekers, say. Often those babies are too unwell to have scanning, certainly a CT scan, which the term babies might get, and that's a really nice way of visualizing the gland. Talking from New Zealand, we did a 10-year audit recently. Most, but not all, babies had transient disease, meaning they were able to come off their thyroxine aged 2 to 3 years, but some didn't. So it's just a more likely versus less likely.
Thank you. And I've been naughty, and I might just ask one more directly to you, and that's this is from Mercy Thomas, and hi Natasha, the difference in TSH at 2 days and 14 days for a preterm newborn screening, is it only due to the maturity difference?
Yeah, so the question being, why would the baby have a normal TSH early and then a higher TSH later? Yes, that is thought to be the reason why. And again, from our recent New Zealand audit, there were just very few babies that you could pick up at day 2. So we feel very strongly that these repeat assessments are necessary in order to screen these babies properly.
Thank you very much, and thanks for stepping in a little bit early, Natasha, there. Sally, I'd like to
Can you hear me now?
Beautiful.
Thank you. Well, I'm going to start by what I was saying is hello, everybody. Good evening. Natasha, thank you for a fabulous presentation. And I just wanted to also reiterate that newborn screening is just not a test. It actually is a system or a process that involves multiple participants. And I think your diagrams describe that beautifully. So I'll stop talking with this bit and let's get the show underway. So today we're going to talk about congenital hypothyroidism, as we've said. So firstly, I'm going to say thank you to everyone for taking time out of your busy day to attend tonight's forum. I'd like to thank you for the last 3 years in particular due to COVID. It's been especially difficult for everyone, including the newborn screening staff. And I'd like to thank everybody who's attending tonight for helping us keep every baby in Victoria safe through the newborn screening program. I'd just like to mention too, if you have any questions during the presentation, please pop them into the Q&A, and Mel's monitoring that. Now let's just see, hopefully now it's all going to go to plan. So Natasha's kindly stepped in for the first one, and I'm going to do the review, the specimen collection guidelines, and I'm going to do to understand the recent changes and why we need the repeat samples. So firstly, I think it's really important that we remember that the goals of the newborn screening are and what it is for a screening test. So newborn screening identifies babies at risk of having a rare but serious medical condition, hopefully before symptoms develop, that has the potential to cause death or disability. Newborn screening is by definition not a diagnostic test, so confirmatory testing is needed to be completed when we have a positive screening result. So that means a referral to a specialist clinician at either RCH or at Monash Children's, which is dependent upon the postcode of the newborn in Victoria. However, with some conditions, for example, metabolic conditions, there is only one centre, and that's at RCH. Each of the conditions has an optimal screening window for the greatest chance of diagnosis, and we want to pick up the babies as early as possible so that treatment can start before symptoms or permanent damage occurs. The ideal window is different for preterms and low birth weight babies in comparison to normal term babies, in particular for conditions such as cystic fibrosis, congenital hypothyroidism, congenital adrenal hyperplasia, which we currently have on the panel. And as Dr. Greaves mentioned, Rhonda mentioned, we will be adding SCIDS or severe combined immune deficiency later on, hopefully by mid-year. So that also has to come into consideration. So I'd just like to share a few facts with you, which I found fascinating through the Clinical Laboratory Standards Institute. So as we know, newborn blood spot screening aims to detect treatable diseases before physical damage can occur. And we need to be mindful that CAH and metabolic conditions can present before newborn screening is actually taken. So worldwide, there's approximately 135 million births per year. Of those, 15 are preterm. 30 million are low birth weight and sick babies, and 739 million newborns are born with serious birth defects, of which 303,000 will not, 300,000 will not survive the neonatal period. And in Australia, we have a prem rate of about 7%. So why change? So the aim of the changes are to create uniform screening standards for all the newborns in Victoria, to remove the confusion around the protocol for weights and transfusions, to remove hospital-to-hospital variation with different flow charts, different ways of doing things at the bedsides, improve the communication between transferring hospitals from a baby that's picked up at a regional hospital to the transfer to the children's hospital, to define blood products that are known to interfere with newborn screening results, and assist in the compliance across the whole of the state so that we ensure that every baby is given an appropriate screen for its gestation and its weight. So the first change I'd like to discuss out of the two is sample collection timeframe. Currently, the collection timeframe is 48 to 72 hours, and it's been like that since 1966 when the program commenced in Victoria. So what happened? COVID happened. It was the great unknown. We were receiving phone calls at numerous times. Scenarios were being put to us that discharge would happen early, that there may not be possibilities of getting back out to do home visits. It was just a bit of a, everything was everybody, everywhere, everybody didn't know what was going on. So not wanting to place extra burdens onto maternity staff to perform recollections, if visits couldn't be possibly made within the timeframes that we needed to urgently assess our protocols and cutoffs. how early could we accept samples being collected less than 48 hours? So a new project was needed to review the data. So a review and analysis of the data from New Zealand and Australia was undertaken to determine if acceptable cutoffs could be implemented for samples collected less than 48 hours. We had to determine the impact of the new cutoffs on recollections and false positive rates. It was easy as we have many normal babies to be able to be checked against. But actually confirming that the new cutoffs were suitable took a lot longer, as we needed to be sure that we were not going to miss a positive case, as these conditions are so rare. So we changed to 36 to 72 hours. And we're confident that after the last 3 years of analysis, that this will be the way that we go forward from now on as of tonight. The second change to the program is the guidelines for the collection of premature sick babies and low birth weight babies. Now, for those of you that work in special care nursery and NICU, you are fully aware of the current collection guidelines, but there are many of you out there that may be very unfamiliar with what actually happens. We currently have a premature low birth weight protocol, and we have a transfusion protocol. We have recollections for babies that are under 1,500 grams and under 1,000 grams. And we have different protocols for those babies that are having transfusions. Can you get the sample before the transfusion starts? Did you manage to get that? No, I didn't manage. So then you need to get it at 48 to 72 hours. Then you need to get it 2 days after you've last transfusion's finished. Then we need to get one at 21 days. And the phone calls that we yielded in the laboratory were a lot of confusion. But if you happen to put a 1,000-gram baby that's had multiple blood transfusions into the mix, it just caused a lot of headaches. So it led to confusion and a failure to adequately screen the most vulnerable of the babies that we have here in Victoria. To validate that, with what I just said, is that we did an audit, basically. We've got all these new tests that are going to come online, and we had to determine were all our low birth weight babies being screened appropriately, because they're the ones at most at risk of not being detected. And they're the ones that need the repeat samples. So we did an audit between 2018 and the first quarter of 2022. It totaled a number of cards delivered to the newborn screening laboratory of 348,584. Out of those, documented babies between 200 and 140 and 1,499 grams. There was 2,647 of those. On review, 76% of those babies did not have that second follow-up sampled, as was written in the protocol. This meant that 24% of the babies were not being appropriately screened for. So therefore, a new protocol was developed to help streamline repeat samples to ensure all low birth weight babies, premature babies, were appropriately screened, and those with transfusions also. This is the protocol that we've come up with. Now, this is the one that we've got in the laboratory currently. The one that will be sent out, I'll show in just a moment. This is nice and colourful and big and bright. So it incorporates both, as you can see, the prem babies and the blood transfusions at the same time. So we've got prems less than 1,500 grams or less than 32 weeks. We've got sick prems, which indicates a baby needing or likely to need a transfusion obtained before the newborn screening routine test is usually taken. Sick term. Now, term probably wasn't the right word, but we mean any baby greater than 32 weeks that is needing or likely to need a transfusion before obtaining a routine newborn screening test. And then we've got all other infants. So for our first sample, screening is to increase the probability of obtaining a newborn screening from every baby, therefore ensuring the risk of being missed is decreased while capturing those having early transfusions. The second sample is when the reliability of diagnosis of most of the conditions will take place. The third screen is the thyroid function may take up to a month to mature and therefore the most reliable to detect a preterm baby with a delayed rise of a TSH, as Natasha mentioned just previously. And the fourth screen covers those sick preterm babies less than 32 weeks that have had a transfusion or multiple transfusions to ensure that they have been screened appropriately. We've also provided a definition for blood products that affect newborn screening. Red blood products mean packed red cells or fresh whole blood transfusions, or ECMO, as this procedure requires exposure to red blood cells and should be considered a transfusion of blood products. This will be the chart that the newborn screening liaisons receive when a recollection is being requested. When the cards are filled in, it automatically will be generated with the recollection letters. So that, look forward to that. This will take place as of April 17. We also have a new screening card that is commencing in circulation as well. And that is includes the transfusion date and the pre-transfusion to be ticked if appropriate. So the protocol: to minimise the risk of missed or delayed diagnosis and treatment, ensuring that every baby has newborn screening, the specimen is collected at the appropriate time to identify, refer, and treat affected newborns, while understanding that newborns have limited blood resources, which may limit collection options. These are recommendations and at all time clinical judgment should prevail. I'd like to thank Lauren Cross from RCH for the help with this protocol, Dr. Pitt and Grace for their assistance with the information from our presentation tonight. And I'd like to remind everybody, we've got references as well for the Clinical and Laboratory Standards Institute for Preterm Low Birth Weight Babies, Sick Babies from 2019, and the Department of Health Newborn Screening Management Report. I'd also like to remind everybody that education is the cornerstone for the program. It's a free service available for all maternity providers, no matter how big or small, or any stakeholder with an interest in newborn screening. It is available in whatever format you wish, and it was lovely last week to be able to do a face-to-face with the girls from the Royal Women's Hospital. It enables us to stay current in our knowledge so that we can speak confidently with our families to assist them in making an informed choice about newborn screening. And by being competent, ensures that the families feel that their baby is in safe hands, while also providing the lab with quality samples to ensure testing can be completed in a timely manner. Please be mindful that the website is full of information and the e-tool and resources for the parents through the Better Health channel. We're also available for contact by email and phone via the laboratory. Thank you, and I'll hand you back to Rhonda now for the Q&A session.
Thank you, Sally. And Natasha, could you please join us? Lovely. Thanks, Natasha. There's a few questions here, and I'd like to start with and probably an easy one for Sally. And I've noticed that there are two different types of NST cards around. One requires me to write the birth weight. The other requires me to write the current weight. What's the difference?
The difference is that one is an old card and should be out of circulation, and that the one with the birth weight is the current weight, one that is in circulation now. So what happens is sometimes if there's been too much being ordered, the old cards haven't gone through. So just check at the side of the card. You will see that there'll be lot numbers and dates on the side of it, but the birth weight is the most current card that we have currently. And as I said, the new card with the pre-transfusion will be coming out as people start to order those.
Yes, thank you, Sally. If I may also just step in on that a little bit, is we have been doing some minor updates of the cards over the last few years, and we did notice that the birth weight versus the current weight, and the current weight was causing some confusion also, so with protocols. So there have been some tweaks, and we are trying to take suggestions. Another change was actually adding the 2 hospitals to the card. So for these prem babies that are often transferred between hospitals for management, that there was a better system for communication. Sally, I'll just go to another one. Hi, Sally. Great presentation. Is the new protocol available on the newborn screening website?
The new protocol for the preterms and low birth weight will become available as of April 17. We've just going through currently, and we're updating all the collection guidelines and everything. And that's all in the process, ready to go live at that period of time.
Thank you. Not sure whether I missed that, whether I've answered the right one then. Okay. This one could be for Sally, or it might be for you, Natasha, as well. When we need to call a family back for a repeat NST, what's the best explanation for our families with equivocal results, as well as referring to VCGS? So what's the best thing to tell the families when it's a clinical recollection request?
Would you like to have a go, Natasha?
Oh, sure. I think that's quite a difficult scenario for families, because you want them to understand that the test was not completely normal, but you don't want to give them unreasonable level of anxiety about, oh, my baby's got a disorder. So I guess the way that we have come to deal with that in New Zealand is that we actually text out information sheets relevant to the result to our midwives to help them to counsel the families. In fact, the metabolic one is very generic, and it talks about reasons why the result may be abnormal, perhaps because the baby is because the sample was a long time in transit, or because the baby was born early, or perhaps there's too much blood spotted onto the card relatively, and that if we were worried about the result in the baby being urgent, we would be calling the back in immediately. But this is just a slightly abnormal or borderline result. So the best thing to do is to send another sample to the lab so that the lab can double check the result. If it's normal, that's great, end of story. But if it's not completely normal, then that will be the point that their baby needs to be checked out by a pediatrician. And I imagine that you have a similar approach in Victoria.
Yeah, and we've actually done an audit, if I may, where we have found that 1 in 5 repeats for a TSH recollection will go on to a referral currently, so 20%. And I'll hand over to Sally because she was involved in that audit, and we'll also have advice on this question.
Yeah, I just can only reiterate what Natasha said. We don't have a handout to give to the midwives to speak to the parents, but I think just keeping it general in facts and ensuring that the parents understand that it is a screening test and that the baby's been identified, but we need to repeat the test to ensure that the maturity of the baby, that we take all those considerations, the gestation, all those sorts of things, what's going on with the baby. And that, as you said, Natasha, that if they would have been called straight away if we were really concerned about it. And that often babies have a borderline level that when we repeat the test, it will normally be normal. But as Rhonda said, within our cohort, we've got about 1 in 5 will convert at that stage, and that they will be contacted straight away by the clinicians from Royal Children's Hospital or Monash Medical, and that treatment will start basically straight away once the baby's been seen and the family being counselled regarding what's going on.
Thank you, Sally. I think I might just continue with a question that's come in. It's a later one. It's about what support services are available for the families who are diagnosed with a condition through newborn screening. So I think that probably follows on from what you've just said, Sally and Natasha. So
yeah, so I would say, so depending on which hospital it is, I can only speak to what happens really at RCH, just with my involvement with the metabolic team. So the same would go for endocrinology. The screening laboratory received the result. It meets the criteria that they need. That gets sent straight down to usually the registrar, who then is responsible for contacting the family. Through that, they organise all the follow-up testing, where they have to go, what has to happen. They'll call the family in, and they will have the first appointment with them with a consultant, and all the testing performed, and they'll be counselled. There's usually social work. Everybody's involved with them from the beginning until they get the diagnosis.
thank you. There's a couple of clarification questions here also. The first one is, at what time do we do the weight?
So the weight is the birth weight. I think that's what's currently on the card. That will be the new card that we have, which is also the card that currently is. I'll just go to my notes here in front of me. It is the current is the birth weight. And the reason for that is that that's the most common thing that's known at the beginning with the gestation of the baby. And what happens is that what was happening out in the community is that midwives were weighing babies, then they weren't weighing babies, and then the protocols of the hospitals were, well, we don't want to weigh a baby till day 5 of life. So that means, do we have to weigh them at 48 to 72 hours when we do the newborn screening test? Then, as we all know, if you weigh a baby at that period of time, it's more than likely lost 10% of weight. So then that throws it into, we have to do a different protocol because of the weight loss, etc. So that's when we came back to putting the birth weight onto the card, as that was the most stable that we had, and that nobody then had to change their policies and procedures around what they wanted to do out on with domiciliary and those sorts of things. And particularly during COVID, it may have been the only test that was done for a little while. So the birth weight is what currently is on the card. Makes us easier.
Natasha, do you know, with the birth weight versus the current weight, with some of the studies, and have they always used birth weight?
As far as I'm aware, yes. Yep.
And is that the scenario in New Zealand?
Yes, we've had that discussion, especially in terms of CAH screening and whether you work on your original birth weight or whether you try to work on weights over time, and we've come back to the point where we just work on the birth weight. We find it simpler, and that's where the evidence that I've been able to see is based on.
Thank you. We've just had a response from Samantha from Queensland, that Queensland uses birth weight. So that's one thing that we've managed to harmonise, at least with 3 of us. But yeah, thank you, Samantha, also for that. So I have a question about will Victoria introduce post 10% dextrose repeats? And will the influence and will this influence your flow charts? Sally, are you on top of this one?
No, I'm not. Sorry.
That's okay.
Is that a question from Queensland?
It's anonymous, so but
Anonymous.
I think it might be from. I'm guessing it might be from Queensland. I've got a yes further
Yeah,
down.
Samantha. Yeah, no.
So
no, I've never. It's not something. I know sometimes midwives write it down, but it's never affected the screening that I'm aware of in the time that I've been. So I'm not sure I can actually answer that.
Yeah, I think I probably can, because I did quite a lot of reading, and I imagine, Natasha, you might have something up your sleeve as well here. So with this new protocol, we've done quite a lot of background reading around this, and we couldn't find anything around the 10% dextrose that would actually support our introduction, bearing in mind we do not screen for galactosemia in Victoria, and so we haven't looked at that in relation to galactosemia, but there was nothing in the preterm sick neonate guideline from CLSI that supported, and we didn't really find anything else in the literature, and we don't feel for our purposes that it affected screening. So the short answer is no. Will we keep an open mind? That is always a yes, but we felt we didn't need to consider that in the flow chart, and we did discuss it and look into it because we realised there was a difference with what Queensland is doing. Natasha, do you want to add anything to that?
Look, I would just say that from the New Zealand perspective, we're the same as you. So we would keep an open mind for sure. But it's not something that we've found evidence to want to introduce yet.
Thank you. We've got one so from Deborah Gordon. I'll go back to Sally. Do you advise the wait to be done at 36 hours or 48 hours? I think
now that we've just been having this discussion, that the birth weight is the most appropriate weight to put onto the card. That's what the card is asking for, is birth weight.
Right.
So I think if we all stick to that, we'll be all on the same page.
Yes. Now, a question from Sarah. I am realising we've got 5 minutes to go. And if we've got unanswered questions here, we will try and answer them afterwards directly to you, and you're welcome to send in some more questions after this as well, directly to Sally, Natasha, or myself. So the next one is with twins, and this is Sally for you. With twins, do you still collect from both when one comes back as recollect or needs a second sample?
I don't have the twin protocol in front of me. However, it depends on whether they're in the same ward at the same time. So yes, the answer usually is yes, particularly if the two twins are in the same room, and there could have possibly been a mix-up with those babies. However, if you have one that's been taken to another hospital that has the issue, and you can definitely prove that one was in one hospital and one was in another hospital, that's a different scenario. But definitely both twins need to be recollected if they've both been in the presence within the same room at the same time, because mix-ups do happen. Yeah.
And what we're aiming to do with the new letters that we'll send out, if it is a twin, we will also, besides the Prem sick protocol, there will also be the twin recollection protocol that will be added as another page. So you'll have both of them there to make that decision and risk. One for Natasha, though, I don't think you can quite answer now. It's from Samantha, again from Queensland. and it's about the 10% dextrose. This is proving quite difficult for us. I have one small study I can send you. I think, Samantha, I think that we should probably look at this as part of the HGSA committee for newborn screening rather than it necessarily coming to Victoria. And Natasha is the chair of that committee, which is why I'm highlighting.
Yes,
So-
please, Samantha. I'd love to see the paper.
Yeah. So if you send it, happy for you to send it to me, Samantha, and I'll forward it to Natasha, because I think it's probably a more national Australasian answer that we should be having the discussion rather than what Victoria does versus Queensland, if that's okay. So Karen, right, I think midwives might now be confused about general follow-up weights, not in relation to the newborn screening. I suppose it depends on the hospital protocol. That's probably a comment to you, Sally, and that we might need to do some more education and work around this, I think.
Okay. Send your invite in.
Yeah, Maria Glover. Sorry, Maria, for leaving. Marie, sorry, for leaving this for so late. There's some evidence that large weight loss in babies born after a long labour, with mother having significant volumes of IV fluid. Is this an issue? And
What do you
Sally, I
think?
think that's. We
No,
haven't identified it as an issue.
No, we haven't identified as an issue. I don't think that'll affect the baby's thyroid function and those sorts of things, I think.
No.
Would you agree, Natasha?
Yeah.
Thank you. I've managed, it's 7:59 and I've finished all the questions. So I think that leaves me about half a minute to say thank you very much to Mel, who's hiding in the background, first of all, and running this forum for us, and to Natasha, Dr. Natasha Heather, for coming in from New Zealand to present at this quite late hour for you, and to Mrs. Sally Morrissey for her great presentation also. And I'm really pleased. Thank you everyone for attending tonight. This will be recorded, or is being recorded, and so will be available to your colleagues to listen to through the VCGS website. Thank you very much for coming, and I will leave it there. Good night.
Night, everyone.
Thank
Bye.
you.
Bye. Bye.